Hi, I'm Michael Patel, President and founder of the Fatty Liver Alliance, on the road again in Milan. I know you've been watching all week. We're at the Madrigal booth again, and we were here at the DDW, but I have a very special guest, Louise Campbell from Towers Health, and we're going to use these really amazing models that Madrigal created and explain a little bit more about liver health assessments and how they relate to the real world, really. So let's check it out. Louise.
So basically, what we're looking for when we do liver stiffness measurements or attenuation of the liver fat is we are looking to differentiate between this normal,
So this is
beautiful, healthy liver that glows and is really shiny. And what we're trying to do
Let's
is
show the inside too. So just to show the inside of each of these as it progresses
beautiful.
too.
You have it on your plate, it's really nice. You look at it in the butcher's, deep purple. But what we're trying to do is work out non-invasively with these devices these different levels of risk and disease. So if I do a fiber scan and I see somebody with a cap of over 250 on average, I am knowing that this liver starts to look like this. It's slightly yellow, you've got fat, but there's no stiffening in it usually at that stage. But what we're trying to work out is this attenuation of the fat through. We're calculating it. We're putting a score on it to tell you you have a risk of poor liver health. You may not have any stiffness, it's lovely and soft. As we progress up and we get to NASH and MASH, we're going to see a lot more inflammation. We're potentially going to see a lot of stiffening in that liver.
So this starts to get a lot.
Yep.
This is much harder to press.
Yep.
Right? So
and
the
we
elasticity
see
is
those
higher.
in the scores of any liver stiffness device. You will see the score go up. Whether it's MRI, whether or not it's FibroScan, whether or not it's a hepatoscope, or any of those devices, you will see this progress.
Okay.
So it's not just any device. That's what they're designed to do.
Now we're getting more advanced here,
to
right?
pick up the stiffening of there, but they're designed to give you early warnings of disease.
And what are we looking at here, Louise? So this is the scarring that starts to occur.
You're now getting fibrosis through and the scarring of that tissue which stiffens the liver up. But remember, the liver is highly regenerative. No cell is over about 150 days old, so everything else in there is regenerating nicely. But we've now got scar tissue.
And
That's
this is still treatable until we get to the next model.
All treatable.
Here comes the battle.
You can make a lifestyle change. You can change your outcomes. All of these become more and more associated with type 2 diabetes, cardiovascular risks.
And pharmacologically on those two.
Absolutely. And then we have cirrhosis. We're talking about shape change. But when we're talking about liver stiffness, we're talking about liver stiffnesses in the teens, 20s and 30s. And for most people, this becomes the point of no return. There will still be progressive regeneration in these people.
So, but this would still be, can we differentiate compensated or decompensated in the way that we're looking at the model?
No, for me, that tends to go around the symptoms around it. You develop ascites, you may become encephalopathic if you've got an infection. But one of the fastest changes are people who go from compensated cirrhosis to decompensated.
Yeah.
So we've got to keep people fit and healthy, doing well, taking medication where they're on it, but also monitoring, because what we're monitoring a liver with cirrhosis is we're monitoring twice a year.
This is not good at all.
We're looking for these masses where we know this is a risk of this, so we're trying to protect and know. But throughout the chronology of this change, it can be 30 years. So we've got plenty of time, primary care through to specialist care, endocrinology, cardiology, to be locating these patients.
And
that's what we're looking to do.
The percentage-wise too. So if now we're saying about 38% of the population has MASLD, and about 20% of those are going to develop to MASH, and then through those stages, and then out of those, another 20% in time will develop cirrhosis. And what percentage gets to this very terrible level of disease?
Well, one of the problems now, I don't know the percentage, but liver cancer is one of the fastest growing cancers and least survivable, and we've got all of this time to find it. that's what a non-invasive device is about. To
Early
look at the
detection,
stiffening,
early
detection,
assessment, early treatment.
and helping people make a change. And it only needs to be a small change. You can take a small change to get from here to here or from here to here for some people.
Louise Campbell. It's awesome seeing you in person instead of on the little screen. Thank you so much for watching today, and we're going to have lots more to come still. A few more days left at EASL.